we are going to do a series of grand rounds. And yesterday we started the grand rounds with Professor Anthony, who is a professor of Madras Medical College. And we did a wonderful session on ear. And we will be continuing with that. The candidate is Dr. Sara. And Professor Anthony is he's a very, very well-known, renowned professor from Chennai Medical College. He's been an examiner for many, many years now. And I'm sure that all of you will benefit from this broadcast. Tomorrow we'll have a nose case, but today I request Professor Anthony to ask as many questions as possible, because this is going to be the sort of, question bank. So we will have a lot of questions about facial nerve, about so many aspects of the ear. And without much ado, I hand over the dais to Professor Anthony.
Welcome everyone. Hope I am audible.
Professor Anthony, over to you.
Am I audible? Janagram, am I audible?
Professor Anthony?
Am I audible? Hello?
Yes, I can hear you.
Am I audible, Sarah?
Yes, sir, you're audible, sir.
Okay, fine. So we start from where we left yesterday, right?
Yeah, we finished with the diagnosis.
That's what. Sarah, what's the diagnosis? Can you repeat the diagnosis again?
Yes, sir. My diagnosis is right-sided chronic otitis media, sir, with unsafe type of ear, sir.
Yes.
With active squamous cell disease and moderate conductive hearing loss without complications, sir.
Your diagnosis should have an anatomical diagnosis, pathological diagnosis, and functional diagnosis, right? The anatomical diagnosis, there is a problem in the middle ear. That's an anatomy. Right side, is there a lesion? If there's a lesion, where is the lesion? So this is a right ear, middle ear pathology, right? The pathology is not tumor, but the pathology is infection, chronic infection. It's a squamous cell type of disease, right? Then it's an active disease with a moderate conductive hearing loss. Okay, how do you proceed with this?
I would like to investigate the patient, sir.
Yes. Okay, what are all the investigations you do?
First, I would like to do examination under microscopy, sir.
Microscope? Come on, you are from MMC.
Autoendoscope, sir.
Autoendoscope. You do it automicroscopic or autoendoscopy examination. What are all things you see with? Will you do it under anesthesia or without anesthesia?
Sir, it can be done as an OP procedure initially. Without.
Yes. I'm asking about anesthesia or without anesthesia.
Sir, without.
The perimatrix will contain granulation tissue, is it?
Yes, sir.
If it contains granulation tissue which is sensitive to touch, isn't it?
Yes, sir.
So it is always safer to do an automicroscopy or autoendoscopy examination under local anesthesia, preferably in a outpatient theatre-like setup, so that you don't do it just in the OPD, but you take it to a theatre-like setup like our DLE room and do an automicroscopy examination. If you do it under local anesthesia, you can manipulate the ear better compared with that of without anesthesia. Okay, so when you look inside, what are all things you are expected to see in a case of a cholesteatoma?
Sir, I'll be looking for any granulation or polyp.
What is the granulation tissue?
So it is an inflammatory reaction of the because of the proliferation of fibroblasts and other foreign body giant cells and other inflammatory cells.
And the neovascularization. So how do you differentiate? If you see a red mass in the external aortic canal? Okay, what is the differential diagnosis? Reddish mass in the external aortic canal or on the tympanic membrane. What's the differential diagnosis?
Sir, it could be meningitis, sir.
Okay.
Or it could be, if it is behind an intact tympanic membrane, it could be a glomus or active otosclerosis.
That's called
Flamingo sign.
flamingo sign. Then,
Sir,
okay, external canal.
malformation.
External canal, you have external canal granulation. Okay, it can be a keratosis obstruans. It can be a external canal cholesteatoma. Then you can have a meningitis granulosa. Okay, then you can have a polyps in the external artery canal, or it can be a benign epithelial hyperplasia of the external artery canal. Bulge in the external ear like osteoma, also sometimes if there's an inflamed overlying skin, can present as a reddish mass. Okay, but generally speaking, these are all the conditions like otitis externa, the granulation tissue in the ear. There's on the floor, the junction of a bony cartilaginous junction, you get a reddish granulation tissue, which is painful, usually seen in a immunocompromised patient or a diabetic patient is what?
Malignant otitis externa.
Malignant otitis externa. Then it can be a keratosis obstruans. Then you can have a meningitis granulosa. It comes when you keep on rubbing the ear with the foreign bodies, it can produce reactions. It can be an external canal cholesteatoma. So all these conditions produces the granulation or a reddish mass in the ear from the external artery canal. From the middle ear, what are the two common conditions?
So reddish mass, sir.
Reddish or pinkish mass?
Glomus and...
two common conditions. Both comes in different types of different types of chronic separate media.
Sir, if middle ear granulation. Sir.
Middle ear granulation, then oral?
Polyp.
Oral polyp. Okay, how will you differentiate an oral polyp from the granulation tissue?
Sir, the appearance will be smooth and glistening in case of a polyp.
Smooth and pinkish in a case of an oral polyp. In a case of a granulation tissue?
Surface will be boggy, irregular, sir.
Irregular surface, granular surface, reddish in color. Polyp is not sensitive. Granulation tissue is very sensitive. Polyp usually doesn't bleed on touch. Granulation tissue usually bleeds on touch. Okay, and it's painful. Okay, polyp is pedunculated. Granulation tissue is sessile. Polyp can be probed all around and seems to be arising from the middle ear. The granulation tissue is attached to any one of the wall of the middle ear. It is sessile, so you can't probe around that wall. Okay, usually both the things are all in the unsafe disease or reticuloantral disease, but most commonly the granulation tissue is granulation tissue is a important finding in the squamous disease. Okay.
Yes.
Right. Then what are all the other conditions? Reddish mass in the ear.
Sir, any malformation?
No, we have talked about external artery canal. We have talked about two conditions comes in CSO. What are all the other conditions?
Sir, it could be a high riding jugular bulb.
High riding jugular. So first is your, as you told, it can be a glomus jugular or flamingo tint, then high jugular bulb, then anteriorly you see the reddish tympanic membrane.
It could be aberrant internal carotid.
Aberrant internal carotid artery or aberrant arteries in the middle ear. Okay, then what else? External canal malignancies.
Yes.
A parotid tumor comes to the external artery canal. Then a middle ear malignancy, temporal bone malignancies. Okay. Then bone malignancy, bone conditions like histoplasmosis X or plasmacytoma. Then you get all these conditions will mimic a reddish mass in the external artery canal. That's your theory question. Okay, so you classify as a external ear conditions, inflammatory middle ear conditions, normal conditions which will present as a reddish mass behind the intact drum, and then other malignancies like. Okay, you got to classify like that, and then you got to write. Okay, then what else you see? When you see a cholesteatoma, you see the when you see a cholesteatoma, you see a debris, you see a matrix, and look for perimatrix. The perimatrix contains these granulation tissue, chipped up bones, and things like that because of an inflammatory response of a cholesteatoma matrix. Okay, then what else you will look for?
Sir, I'll try to see the end of, if I'm able to make out the extent of the cholesteatoma. Sir.
Okay, very good. Then,
sir, and any epitympanic structures are eroded or not?
Okay, that we have seen this already. Then, will you do any other test along with this automicroscopy?
Sir, I'll do oral toileting and send pass for culture sensitivity. Sir.
Why?
To find the organism which is.
What difference that makes? Okay, if you find the organism, then when you give you want to give an ear drops along with an organism?
No, sir.
These broad spectrum ear drops. Why this organism you want to find out? Is it a medical disease?
No, sir.
Cholesteatoma is a surgical disease. You don't operate unless whenever there is a inability to operate. Or all other conditions, you see a cholesteatoma, you prepare the case and operate. Right. So when you want to operate the patient, you got to give an antibiotic in the perioperative period. It's called an umbrella cover. You start an antibiotic pre-operatively on the post-operative period, you cover with an antibiotic. To select an antibiotic, it is advisable to do a pus for culture sensitive. Okay? Right. Tell me then, what other investigations you do?
Sir, if there is any granulation, it can be taken and sent for biopsy, sir.
Okay. To rule out all these conditions, what we have discussed now.
Yes, sir.
Okay, taking biopsy without anesthesia is difficult. So it's always preferable to do it under local anesthesia. Okay, then.
So then Manto and Pasca, Manto for ruling out tubercular otitis. If
tuberculous otitis?
Sir, then audiological investigations.
Audiological investigations, okay. What investigations you do?
PT, sir.
Pure tone diagram, yes, right. What do you look for in the pure tone diagram?
Sir, I'll look for the type of hearing loss, degree of hearing loss.
Okay. What are the advantages of taking audiogram?
Sir, it will help us to follow up the patient post-operatively and for medical legal purposes, documentation.
Cholesteatoma surgery is a surgery where you want to maintain the hearing loss or want to improve the hearing loss. To improve the hearing loss, you should know the quantity of the hearing loss and quality of the hearing loss. That is the main reason you want to do a surgery. In a patient who has got a poor cochlear reserve, or a patient who has got a dead ear, you will not do a fancy canal wall up surgeries. Okay, if the patient has got a no hearing or dead ear, what surgery you do for cholesteatoma?
So, modified radical mastectomy with the obliteration of it.
What is that called? When the patient has got no hearing, why you want to do a modified radical mastectomy? You do a radical mastectomy. Okay, what are all the Indications for radical mastectomy.
Sir, any cholesteatoma which is extending into the eustachian tube or
Okay, eustachian tube cholestoma, because when you remove the circumferential cholestoma from the eustachian tube, the eustachian tube will become useless. So once the eustachian tube is non-functioning, there is no point in doing a tympanoplasty. Okay, then.
Yes. Sir, when there is chronic perilabyrinthine osteitis.
Labyrinth. When the labyrinth is dead, the non-functioning vestibular apparatus or non-functioning here, then you do a radical mastectomy. Anything else?
So then
Cochlear promontory fistula.
Cochlear promontory fistulas.
When the patient has got a profound sensorineural layering loss. So all these conditions, you do a radical mastectomy. Okay, so radical mastectomy is done for eustachian tube infiltrating cholesteatoma, cochlear promontory fistula, dead labyrinth or perilabyrinthitis, and then the patient who has got a profound sensorineural layering loss. And then other causes like when you do limited malignancies and things like that. But for a cholesteatoma, these are all the indications to do a radical mastectomy. So to do a radical mastectomy or do a modified radical mastectomy, you got to do a check the patient for audiological findings. Okay, so you do a pure tone audiogram. Then.
Sir, then radiological investigations.
Okay. What radiological investigations you do?
So X-ray mastoid.
X-ray mastoid is called what? What
sir, view. Schuller's view, sir.
What X-ray we take? Huh? Loss view or lateral oblique view with 10-degree tilt, so that the internal acoustic meatus overlaps the external acoustic meatus. In a case of a cholesteatoma, what are all things you look in an X-ray mastoid?
Sir, I look for the cholesteatoma cavity if it is
cavity. Okay.
There will be surrounding sclerosis.
Okay.
Then position of the tegment plate and sinus plate, sir.
Tegment plate, low-lying dura and forward-lying sinus plate. Usually, cholesteatoma occurs in the sclerosed mastoid, which is very small. These patients are known to have a low-lying dura and forward-lying sinus plate and contracted antrum. So you got to check up how bad your surgical expertise is going to be. Okay. Then what else you look for? Pneumatization
of the mastoid.
Of the mastoid. Which patients you get a cholesteatoma in a pneumatized mastoid?
Sir, in children it is more common.
In children it is more common. So why it is important to know whether it's a pneumatized mastoid or non-pneumatized mastoid?
Sir, if it is a pneumatized mastoid, the extent of spread of disease will be more. Sir.
In the case of a pneumatized mastoid, the cholesteatoma will be infiltrating into all the cells. So the resultant cholesteatoma surgery will known to produce a huge big cavity. So huge big cavity got to be made small. It is difficult to maintain a good cavity. So it is always you think of doing a canal wall up surgery or reconstruction or decrease the cavity size when you are doing a large cavity surgeries. Okay. On contracted antrum, the cholesteatoma will have a blunt end, so you can remove the cholesteatoma easily and it will come out. The patients will do well with the cholesteatoma surgery. Okay. Right. What are the differential diagnosis for the cavity in the mastoid?
Sir, first is a large antrum, sir.
Large antral cell. How will you differentiate that from the cholesteatoma cavity? Large antral cell is?
Sir, there will not be surrounding sclerosis, and it will have an irregular margin when compared to
large antral cell is the part of a well-pneumatized mastoid. So you can see the mass chart is extensively pneumatized. Okay. Then the second one is
next is previously operated cavities.
operated cavity. So operated cavity will have
will be a wide cavity.
Smooth walled cavity and the surrounding sclerosis. How does the cholestoma cavity look like?
So cholesteatoma cavity will be either round or oval with smooth margins with surrounding sclerosis.
And sclerosis, and inside the cavity you have a cotton wool appearance. That's the presence of cholesteatoma. Okay, cholestoma will be it's a soft tissue density. Okay, so you have cotton wool. What are the other conditions can produce cavity?
So eosinophilic granuloma.
Eosinophilic granuloma, yes.
So then tuberculosis, syphilis.
Tuberculosis cavity. Okay, then
syphilitic cavities.
Okay, then Clovus jugular. Clovus jugular can produce cavity. I mean that you have it can destroy the cells. Okay, and then malignancies. In the case of a temporal bone malignancies, you see extensive destruction. Where it will look like a cavity in the in the temporal bone. Okay, right. What other things you will do? What other investigations you do?
Sir, high resolution computed tomography temporal bone.
HRCT. Okay. What are all the indications for CT scan in cholesteatoma?
Sir, if the patient is planned for surgery, to look for any anatomical anomalies.
Okay.
Any course of the facial nerves.
Okay.
Extent of the cholesteatoma.
Okay.
Position of sinus plate and dural plate, sir.
That's all very difficult to see. The cholesteatoma will look like a soft tissue density, right?
Yes.
It will be like a brain or a soft tissue, like a granulation tissue. How will you differentiate a cholestoma from the other tissues like brain tissue? Any other investigation you do?
Sir, MRI can be done, sir.
Okay, what MRI? Specific.
Diffusion weighted MRI.
Diffusion weighted MRI. Okay, that will differentiate a brain from the cholesteatoma. Okay, right. Then what other investigations you do?
So then DTPA can be done, sir.
Which one?
DTPA.
Okay.
Sorry?
Print ini. Print. Nurul Nazira. Ada.
Hello, sir.
Yes, I am not able to hear you. Somebody else is talking.
Oh, tidak boleh. Kawan I, member I.
Hello,
Okay,
can you please
check.
answer, my dear friends? Hey, Harsha.
Print. Apa?
Yes, Sarah, unmute yourself.
Hello, I am muted. Everybody, can you please unmute Dr. Sarah? Please.
Yeah.
There's somebody who is talking.
Yes. Yeah, tell me.
Sir, we can do contrast enhancement, sir.
Okay. No. What other investigations you do?
Sir, MRI T1, T2 images.
Okay, right. Then what else?
There you go, man.
Other investigations, basic investigations for surgery, like
Pre-anesthetic workup.
pre-anesthetic workup. Okay. So, what is your plan of treatment of cholesteatoma?
Sir, depending upon the extent of the cholesteatoma, suitable surgery can be planned, sir.
Okay.
If it is a very limited disease.
Oh, we are talking about this case, right?
Yes, sir. This case, I would like to do a modified radical mastectomy, sir.
Modified radical mastectomy. With, you want to do a canal wall down surgery or canal wall up surgery?
Sir, canal wall down, sir.
Canal wall down surgery. Sure?
Yes.
Okay. If it's a small cavity, will you like to do a articuloanterostomy and then reconstruct or things like that? Okay. So why you want to operate on the patient? Why you can't wait?
Sir, because patient there is risk of progression of the disease and complications.
Why attic disease is dangerous?
Sir, because it is close to the vital structures like.
Okay. It is close to vital structures. Then.
Sir, early it can erode the it can enter into the mesotympanum and.
Okay. See, why attic disease is dangerous is attic is lined by the cuboidal epithelium. The response of the cuboidal epithelium to injury is to produce granulation tissue, and that will erode the bone. It is close to all vital structures like facial nerve, lateral semicircular canal, and tegmen. So when it expands, it can produce complications. It has got poor drainage, got poor ventilation. So chances of progression of the disease is high compared with that of the other areas. That's why we operate. Okay. When you see a small, if the patient is, when you don't have a theater, the patient got to wait for about 15 days, 20 days. What do you do then?
Sir, regular examination with autoendoscopy and suction clearance can be done.
Give a suction clearance. Who else you manage the patient like this? Conservative management.
So patients who are medically unfit for surgery.
Okay. Then?
And patients who are not willing for surgeries.
Okay. Anybody else?
With a very small cholesteatoma, we can wait and watch.
Not with wait and watch. A small cholesteatoma which has got a large mouth and very shallow sac. So these are all the patients, all self-cleaning cavities which are all just getting wet often. So those patients you can just do a suction clearance and watch the patient carefully. Okay, right. So if there's a limited cholesteatoma, what surgery you do? Only for an attic, what surgery you do?
Sir, transcanal atticotomy can be done.
Okay, transcanal atticotomy. Then now, will you reconstruct? Will you reconstruct the outer attic wall?
Sir, outer attic wall can be reconstructed if there is a surgeon is sure that the complete disease has been removed, sir.
If you are not removed the disease completely, what's the point of operating on the patient? You can as well do a suction clearance now. Okay, you do a transcanal atticotomy, then look clearly, remove all the cholesteatoma matrix. But if you are having only a lateral disease, then it's fine. Once you have removed all the matrix, then you how cholesteatoma erodes bone?
Sir, it can cause a pressure necrosis.
Pressure necrosis, then?
Or enzymatic resorption of the bone, sir.
Okay. What are the enzymes?
Various enzymes like cathepsins, caspase 8, other inflammatory markers like interleukin 1, 6, tumor necrosis factors.
Metalloproteinase.
Matrix metalloproteinase 2 and 9.
Okay. Right. So these are all the enzymes. So the cholesteatoma, the bone has got three structures. One is cells, matrix. Third one is calcium. Okay. So the calcium is removed from the bone by hyperemic decalcification. That is, whenever there is an inflammation occurs on the bone, there is an increased blood supply around that area. That is called hysteresis. Because of the increased blood supply, the calcium from the bone goes to the blood circulation. So that will decalcify the bone. This process of hyperemic decalcification is otherwise called hysteresis. Okay. Second one is a pressure necrosis. Third is the inflammatory cells produces giant cells. So you'll have a inflammatory response, produces giant cells. These giant cells join together, multinucleated giant cells join together to form the osteoclast as well as osteoblast. Osteoblastic activity is more compared to that other osteoclastic activity. It eats away all the osteocytes. That leaves behind only matrix. Matrix is made up of proteins. These proteins are all taken care by the all the substances what you are saying. Okay, so that is called hyperinic decalcification is otherwise known as allostasis. Allostasis. Okay, so once you have once the bone is when the cells are all taken, calcium is taken, matrix is removed, the bone gets absorbed. Okay, so the what is the first bone to get absorbed?
Sir, lenticular process of fungus.
Why?
Sir, because the blood supply is poorer in the...
It's got a vicarious blood supply. Where the blood supply from the lenticular process comes from?
Sir, from the middle meningeal artery, there is a branch to the incus, which is called arteria nutritica incudomalleoli.
Arteria nutritica incudomalleoli is a branch of a superior temporal artery, which is a branch of a middle meningeal artery. Okay, that artery anastomoses with the stylomastoid artery at the level of the lenticular process. So that's a long artery, one from the one end, other from the other end. So that place got a vicarious blood supply, can cause lenticular process necrosis. Okay, then okay, we have talked about cholestoma spread yesterday. So then what are all the structures which will get eroded, which can produce complications as a cholestoma erodes?
So ossicles can get eroded, sir.
Okay.
Tegmen plate.
Why it is like this? Facial nerve. How facial palsy occurs in cholestoma?
Sir, because of erosion of the bone overlying the facial nerve, sir.
The facial nerve can be dehiscent at some places, or a bone can get eroded by the cholesteatoma. So that's a perimatrix produces inflammation. This granulation tissue causes the fine blood vessels around the facial nerve will get obliterated. So that's causing ischemia, and then we go for degeneration, produces facial palsy. So which facial palsy recurs better? Traumatic facial palsy, Bell's facial palsy, or a cholestoma facial palsy?
Sir, cholesteatoma.
Is it?
Sir, Bell's palsy has...
recovery is better. Trauma also recurs better, but the cholestoma facial palsy, if it's early stages, it's okay. If it's a full-blown facial palsy, the recovery is not as good as that of the other facial palsies. Okay, so unless you remove the cholestoma, it is because of edema, not infiltrating on the vasculature of the cholestoma. Okay. Then what else it can get eroded?
So semicircular canal.
What semicircular canal?
Produce lateral semicircular canal.
Semicircular canal. So when you see a lateral semicircular canal erosion, if you just remove that sac and leave it open, will it become all right?
No, sir. We have to remove the cholesteatoma, and matrix over the lateral semicircular canal can be left in place. And
that's very old theory. Nowadays, with the good microscopes and good instruments, you can remove it. Okay, the area which has got eroded by the cholesteatoma, surrounding area will have a new bone formation. So once the cholestoma comes off, the new bone grows again and then closes the fistula. That's why we can put a graft over that and come out. That will do. You need not reinforce with the cartilage. Even if you put a graft, if the cholestoma, the erosion is very small, surrounding area contains a newborn formation tendency, so it can close the fistula. Okay. What usually happens is the cholesteatoma will line the lateral semicircular canal and erode the bone, makes a punched out appearance, which will expose the underlying membranous lateral. Unless there is a perimatrix reaction, you get only the giddiness on the fistula test. Otherwise, you will not get any big problems. If there is a perimatric inflammation, then patient will go for serous otitis media. Okay, means serous labyrinthitis. The serous labyrinthitis can get infected completely, become suppurative labyrinthitis. Okay, where will you get fever in labyrinthitis?
So fever is usually not associated with labyrinthitis.
You get suppurative labyrinthitis, won't you get fever?
No, sir. Pus is very minimal amount, which is not.
There is only 1 ml of pus. So 1 ml of pus is like your pimple; it will not produce signs of inflammation. But the labyrinthitis can easily become an intracranial complication, it's like meningitis. If that occurs, the patient can have fever. But only labyrinthitis will not produce fever. How will you differentiate a serious labyrinthitis from a suppurative labyrinthitis?
Sir, severity of the symptoms.
Sarah, you have 2 patients. One patient has got serious labyrinthitis, other patient has got suppurative labyrinthitis. Then you know which is severe, which is not severe. Right? If you have only one patient, the patient has got giddiness, how do you know which is severe giddiness, which is not severe giddiness? What you say is theoretically right, but it's very difficult to assess, right?
Yes, sir.
Then how would you do?
Sir, nystagmus and headache, severe headache will be.
That will be there in all labyrinthitis. Nystagmus giddiness will be in all labyrinthitis, vomiting. Best way to do is, once the disease is over, the hearing loss will improve. If the hearing loss is not improving, that's a suppurative labyrinthitis. The hearing loss is improved, labyrinthine function comes back. That is a serious labyrinthitis. We ask all these questions only to ask you, will you do vestibular tests for cholesteatoma? For assessing cholesteatoma, we do vestibular tests. What test you do?
Sir, caloric testing can be done.
So you do caloric test in an active disease.
Sir, clinically, fistula test.
No. Caloric test will you do or not?
No, sir. Active cases, cholesteatoma.
There are other ways of doing caloric test. What is air caloric test?
Sir, warm and cold air are.
Junda grants air caloric test. That you can do it, right? In our OPD, I asked you to do a caloric test for a patient who has got a central perforation. How will you do it? Will you do it? Have I not asked you?
Yes, sir.
Yes, sir. How will you do? You take a cotton wool, dip it in ether, keep it in the external artery canal. That will stimulate the labrum. So particularly when the patient has got an attack of giddiness, you want to assess whether the patient has got a residual labyrinthine function or not. You got to do a caloric test to see whether there's a residual function is there or not. Okay, so how to do it about it? You can do a air caloric test, or you can keep take ether, dip it in a cotton, keep it in the external artery canal. Okay, that will produce cold current in the external artery canal, which will be taken to the inner ear. The convection current will produce labyrinthine stimulation or not. Okay, so that's a crude way of doing a caloric examination, particularly when the patient has got a perforated drum. Okay, you can do it little confidently in cholesteatoma, not in the central perforation. Okay, so this is about the vestibular assessment. Why you want to assess vestibular function?
Sir, if we have to repair if there is a labyrinthine defect, it has to be repaired during surgeries.
So why you want to assess the vestibular function? You are told dipped in ether. Hello?
Anthony, yes. People want you to repeat the crude way of caloric test.
You told already. You take a cotton wisp, dip it in ether, keep it in the external artery canal. Okay, so that you don't pour water, but you induce a cold air current in the external artery canal, which can stimulate the residual function. When you have a patient who have got a labyrinthitis or an attack of vertigo, who got a cholesteatoma, if you want to know whether the patient has got a residual vestibular function or not, if there is no vestibular function, that's called what?
Dead labyrinth.
Dead labyrinth. What do you do for dead labyrinth? What surgery you do?
It's a radical mastectomy.
You do radical mastectomy. You are not bothered about reconstructing the things, and you are not bothered about making a small cavity, large cavity, things like that. You plug the incision tube, remove all the article, leave behind only that full plate of stapes, and do the blind sac closure and come out. Okay, because to assess that whether the patient has got a function, residual function or not. Okay, so what is your which surgery? What is the indication for modified radical mastectomy? Or what are all the cases you should absolutely do only modified radical mastectomy? Preferably do only modified radical mastectomy.
Sir, when there is extensive aggressive cholesteatoma, sir.
Okay, excessive aggressive cholesteatoma. Then?
So then there is a posterior meatal wall defect which cannot be repaired.
When there is a posterior canal wall is eroded, more than 1/3 of the posterior bony canal wall is eroded, then it is not advisable to do a reconstruction. Okay, then?
Sir, when there is a failure of a previous canal wall up surgery.
Okay, recurrent cholesteatoma, recidivism, then what else?
Sir, patients who are irregular follow-up.
Okay, chip in the shoulder type of patient. They come from long off places. They don't come for appointments regularly. They always complain. Then anything else?
So in sclerotic contracted mastoids.
Do anything. Only hearing aid. If the patient has got a only hearing aid, the chances for sensorineural hearing loss on a cholesteatoma surgery is high when you are doing canal wall up surgery compared with that of the canal wall down surgery. So you do modified radical mastectomy. Okay, a patient who has got already operated on the opposite ear and there is residualism, you want to operate on the other ear, or patient who has got an impending complications, or patient who has got already got a complications, you want to inspect often. All those patients, it's always preferable to do a canal wall down surgery. Okay, what is modified radical mastectomy?
So it is a surgical procedure which involves excineration of all the accessible and diseased mastoid hair cells with complete excineration of the cholesteatoma and
Excision of the cholesteatoma sac.
Excision of cholesteatoma and exteriorization of the cavity into the external auditory meatus.
How do you make the cavity?
Sir, by removing the bridge, and the facial ridge has to be reduced, sir, and a wide meatoplasty has to be done.
Anterior and posterior buttress got to be amputated. Okay, so when you are going to operate on a patient, what is your goals of modified radical mastectomy?
So the goal is to completely eradicate the disease and give the patient a dry ear.
Complete eradication of the disease is called what? This is an unsafe ear. Completely eradicate the disease makes what?
Convert it into safe ear.
Safe ear. So first goal is to make the ear safe. The ear should not use complications. So make the ears safe. Second is?
To make it dry, sir.
Preferably dry predominantly. You can't make it 100% dry always. Why? You are producing cavity. the cavity problems can produce discharge. So preferably it is dry, but sometimes that you can get infection, you can get fungus in the ear, so you can have discharge. The cavity problem is a known complication of known sequelae of a cholesteatoma surgery if you have done a bad cavity. Okay, then what else?
Sir, to restore the hearing mechanism as well as.
Restore the hearing mechanism. You got to restore the hearing mechanism is the third. As you got to maintain the same hearing or you got to improve the hearing. Then anything else? Not for modified radical mastectomy, for a cholesteatoma surgery. Make it anatomically near normal ear by reconstructing or maintaining the posterior canal wall. These are all the 4 main goals of a cholesteatoma surgery. 3 goals you achieve with the modified radical mastectomy. One is safe ear, second is predominantly dry ear, third is with the attaining these two, restore the restore or try to improve the hearing mechanism. Okay, when you do a modified radical mastectomy, what is bridge?
So bridge is that part of the posterior superior meatal wall which is lying lateral to the adductus.
Adductus angle. Okay, what is ridge?
Ridge is that part of the posterior meatal wall which is overlying the which is lateral to the facial nerves. Vertical part.
Vertical part of the facial nerve. What is anterior buttress?
So anterior buttress is a part of the superior canal wall that meets with the middle ear, roof of middle ears.
Or it is behind the temporomandibular joint. Okay, that part of the superior meatal wall which goes and joins with the tegment, or that part of the superior meatal wall which lies behind the temporomandibular joint. What is the posterior buttress?
Part of the posterior meatal wall which joins with the external auditory canals.
Joins with the floor of the external auditory canal. Floor of the external auditory canal. Okay. So these are all the basic things what you do. You make middle ear, attic, antrum, adductus into a single cavity by removing the bridge, reducing the ridge and amputating anterior and posterior buttress. Okay. So what reconstruction will you do? How will you remove the cholesteatoma from the anterior epidemic recess?
Sir, by atticotomy.
You do a modified radical mastectomy. All the ossicles are intact. How will you excentrate cholesteatoma from the anterior epidemic recess?
By removing the head of the malleus.
Okay. Then you got to remove the incus and the head of the malleus. Okay. The incus will have got eroded already. Okay. But sometimes you can, even if it is intact, you dislocate into a separate joint, take out the incus, inspect everything, and use it for the reconstruction. Okay. You got to clip the head of the malleus. What instrument do you use to clip the head of the malleus?
Sir, malleus nippers.
It's called malleus nibbler or malleus nipper. Okay. So you got to excentrate the anterior epidemic recess. Will you leave cholesteatoma somewhere and come? Are you allowed to leave cholesteatoma and come?
Sir, if the cholesteatoma is lying on the footplate of the stapes.
You got to take it out now. Come on. These are all the ages that even with an endoscope we take it out, right?
Sir,
somebody told it's on the facial nerve. Even from the facial nerve, you can shave and take it out. Okay? Where you won't remove, you leave it off and come out is maybe if there is the footplate is very mobile and very thin, you are known to injure the footplate, you can leave behind there and come. Okay? If there is a lining adherently over the membranous labyrinth, or if it is adherent over the dura. For all these cases, you can leave the cholestoma and come. If you leave the cholestoma, what will happen?
Sir, the matrix is there will be surrounding a new osteogenesis.
Okay, so what will happen? This will form an epithelial pearl. Epithelial pearl is much easier to remove than you tear it off from the underlying adherent structures. Okay. Right. What is recidivism?
Recidivism is a residual and recurrent cholesteatoma.
Okay. What is the cause for recurrent cholestoma? What is the cause for residual cholestoma?
So residual cholesteatoma can be due to a high facial ridge. If the facial ridge is not adequately lowered, sinus tympani.
Recurrent cholestoma or residual cholestoma? See, the residual cholestemas are the cholestoma which is left behind following surgery. When you close the surgery, there is cholestoma inside the cavity. That's a residual cholestoma. The residual cholestoma can be left behind adherently or inadvertently. Okay. What is adherently? The cholesteatoma which is, I told you, like over the dura or over the tightly adherent over the fenestra or over the foot plate, or if it is you are not confident to remove it from the facial nerve. For all these things, you know there is cholestoma, you leave behind and come. Okay. Certain places you will inadvertently leave behind cholestoma and come. Where?
Sir, sinus tympani.
What are the boundaries of sinus tympani?
So sinus tympani, laterally it is bounded by the vertical part of facial nerve, sir. Medially the promontory, superiorly subiculum and inferiorly ponticulus. So
Really?
superiorly ponticulus, inferiorly subiculum.
What are the types of ponticulus? What is complete, incomplete, absent? Complete means it's like a dam, it blocks. Incomplete is like a bridge. You have a gap between the bridge and the floor through which a cholestoma can easily travel. That absent is otherwise called communicating, where the cholestoma, sinus tympani communicates with the posterior sinus. Okay, so subiculum is at the level of the round window. Ponticulus is at the level of the oval window. Okay, that is sinus tympani. What is facial recess?
So facial recess is part of the retrotympanum, which is bounded medially by the vertical part of facial nerve, laterally by the chorda tympani, and superiorly by fossa incudis.
So the cholestoma can be left in the facial recess also if the tympanic annulus is very prominent. Okay, so how will you remove cholestoma from the sinus tympani?
Sir, by lowering the facial ridge. Sir.
Sinus tympani. However you lower, that's your lateral boundary of sinus tympani. Then how will you remove? Somebody says endoscopy. Not a lot of people will agree. We do the whole cholestoma with an endoscope, right?
Sir, Zinni mirror.
Zinni mirror. Any other mirror? Whirlybird. Buckingham mirrors. There are a lot of small mirrors can be used. Other technique is you make the patient tilt the patient vertical, or you try to remove it from the opposite side. You go to the head end of the patient, use this microscope, try to see the cholestoma and take it out. There are 3 types of sinus tympani are there. What are they?
Sir, type 1, it is above the level of the facial vertical part of facial nerve, sir. Type 2 is just beyond the level of facial nerve. Type 3 is retrofacial extension.
Retrofacial extension, it is very, very difficult to remove with your microscope. So you need a mirrors, or you need a endoscope to look into. What endoscope you'll use?
Sir, 30-degree.
Sarah, you use 70-degree endoscope, which is 3 mm endoscope. Okay, 30-degree is not much useful. We use 45 or 70-degree endoscope, which are 3 mm, which is used for the inspecting hidden areas. Okay, then what are the other area in the middle ear you can leave behind? The use of endoscope in ear surgery, particularly for a cholestoma surgery, is on the concept that most of the recurrent cholestoma or residual cholestoma are in the mesotympanum, not in the mastoid, it's in the mesotympanum. So every time you see something in the mesotympanum, it is very difficult to see beyond facial nerve. It's very difficult to see with a microscope. So the endoscopes are very useful when you are doing it with the when you are doing a cholestoma surgery, particularly for what is called as a look-in. Okay, that is about the sinus tympani. Okay, what is recurrent cholestoma?
So recurrent is if there is there was any previous surgery we have missed because of in Prozac space.
Recurrent cholestoma is a cholestoma which comes back. So it comes back can be classified as a surgeon factor, or it comes because of the disease factor. Disease factor is pediatric cholestoma. It's aggressive cholestoma. Cholestoma occurs under cellular mastoid. A cholestoma we has got keep on coming. What is that recidivism means?
Sir, both recurrence and residual.
So recidivism is a term which is borrowed from the social pathology. So that is used for the people who are called jailbirds. So these are the people who do some criminal activity, go to the jail, come back, then tend to do the same thing and go back again. Okay, so that is called repeatedly they falling back to go for this original state. That's called recidivism. So we have borrowed it from the social pathology to use for the cholesteatoma, where the cholestoma comes back. So it can come back because you leave behind cholestoma, or it will come back because cholestoma comes. It will come because of the surgeon factor, like you, as you said, high facial ridge. You don't remove the anterior epitympanic cells. You leave behind cholestoma on the retrofacial area, on the tip cells, on the sinusoidal angle, or hypotympanum. Okay, so when you inadvertently leave behind bigger areas like you have high facial ridge, you leave behind anterior buttress, you can have an anterior epitympanic cholestoma, you leave a inferior buttress, then you can have other types of cholestemas. Okay, that's called surgeon's factors. Then patient factor, disease factor is an aggressive disease. For few diseases like malignancies, cholestoma, at one particular time, you got to accept your disease and try to correct it again, like malignancy. Right? You can't keep on operating. You keep on coming one particular point, you got to go for a palliation. Right? So here also you got to one particular point, you got to accept the disease, make the cavity bigger, prevent complications. Okay, so this is about the recidivism. So you have created a nice, beautiful cavity. Will you saucerize the cavity?
Yes, sir. Cavity has to be saucerized.
So there are two ways of doing cholestoma surgery. One is make a very small cavity and then reconstruct the posterior canal wall. Okay, or if you are doing a modified radical mastectomy, you remove completely. You reduce the cavity. You do a good saucerization. Okay, so that is about the. Then what do you do to the cavity?
Sir, after saucerizing the cavity, we have to do a meatoplasty, sir.
Meatoplasty. What are the types of meatoplasty you know?
Sir, corners meatoplasty.
Okay.
Stack meatoplasty, sir.
Okay.
Fish meatoplasty, Sheehy meatoplasty, Portman, modified Portman.
Okay. What is Siebenmann?
Siebenmann.
Then you do what is called as meatoconchoplasty. What is called as meatoconchoplasty. So,
Can you repeat it, please, Dr. Sarah?
Sir, Corner's meatoplasty, Siebenmann meatoplasty, Portman meatoplasty, modified Portman, Sheehy's, fish meatoplasty.
Stack meatoplasty.
Stack meatoplasty.
Stack meatoplasty. So, Siebenmann is you make 3 flaps. Okay, you make 1 flap above, 1 flap below, and 1 flap laterally. That is Siebenmann. Okay, so Portman and modified Portman, you make a T and you make a U. That's a Portman and modified Portman. Okay, so you do a good meatoplasty. What is VS ratio?
So the ratio between the cavity and the ventilation for the cavity and the size of the external auditory the meatoplasties.
When the volume of a cavity is high, when the surface of the cavity is high, you got to increase the volume. You can't increase the volume from the cavity itself. So you make the cavity communicate with the external auditory canal. So smaller the cavity, you do a small meatoplasty like a fish meatoplasty or something like a Corner's meatoplasty. If the cavity is big, you got to remove part of a conchal cartilage also to make it so big that the volume of air in the cavity makes the surface dry. That's called VS ratio. So it got to be, the volume got to be 3 times that of a surface area. So the surface area is bigger, you got to do a bigger meatoplasty. Okay, so there is volume surface ratio. Okay, then once you have sutured meatoplasty, what do they do?
Sir, then after suturing, we'll post-oral wound is sutured, sir. And we have to plan medicated pack.
Keep medicate something in, you get a stent. Okay, the stent can be a medicated pack as we are keeping in our college, or you can have stents for that, or you can cut your Minocell and keep it inside. So a lot of other things are all available. Okay, will you do a tympanoplasty for the patient?
Sir, tympanoplasty can be done, sir.
Can be done. You got to do a tympanoplasty. If you don't do a tympanoplasty, that is not modified radical mastorectomy. What tympanoplasty you do?
Sir, for this patient, I'll inspect the ossicles, sir, and depending upon the ossicular status, appropriate.
Always there are 2 ossicles that are there.
Yes, sir.
Then what do you do?
Sir, type 3 tympanoplasty can be done, sir, or a cartilage tympanoplasty.
Will you do type 2 tympanoplasty? Type 2 tympanoplasty.
Sir, if the incus is eroded and interposition cartilage graft can be kept, sir.
When you are reducing the posterior canal wall to the level of the facial nerve, the depth available of a middle ear will be of only single ossicle. That is the reason you try to do a canal wall up technique. You want to increase the middle ear depth. So only 1 ossicle can be kept. If there is the suprastructure of stapes is intact, then you put a graft directly over the end of the stapes, do a meningostepidoplexy. If only foot plate is available, then you got to augment the foot plate with some material. What is the ideal material? Only if there is a posterior superior retraction bucket cholesteatoma, which erodes the long process, lenticular process, and suprastructure, and a part of a incus. Okay, if that is the case, how will you reconstruct? What is the ideal material to reconstruct?
Sir, Partial ossicular reconstruction prosthesis.
Use something natural.
So cartilage graft can be kept.
Okay. If you want a bone.
Bone or so bone graft or cartilage graft, or we can remodel the incus and replace.
Have you seen me operating? What do I keep?
Cartilage graft.
We asked about some instrument some time back. Head of the malleus. Head of the malleus has got an ideal height. So you take out the head of the malleus, check it out whether there is any residual cholesteatoma with that, just drill it off, make it smooth and keep it over the foot plate. It stays. Okay, it's an ideal size and ideal shape to sit on the foot plate of stapes and ideal height for the graft to sit. Okay, you keep a little bit of gel foam around that so that you keep it in position and put a type 3. Okay, if that is not available, we can do a what do you call this? That umbrella. You can do a cartilage plasty with an umbrella, or you can keep a longitudinal strips of cartilage and then put a graft on top of that. Okay, so these are all the various reconstruction techniques. Of course, you can do a partial articular replacement processes. Okay, right. Then what are the what are the drawbacks of the cavity?
Sir, cavity can produce cavity problems like persistent ear discharge, sir.
Okay.
And if it is a large cavity, it can produce caloric stimulation. Sir.
Okay.
And it will be difficult for the patient to use hearing aids.
Okay. Will the wax get accumulated? Firstly,
yes,
nature will go off, the wax can get accumulated because you have disturbed the external aortic canal. The second thing is the patient can have a accumulation of fungus. You can develop fungus. You can get an otitis externa. Then you can have a chocolate cyst. Then you get a tinnitus called seagull tinnitus. Because of the cavity is bigger, the air goes inside, produces noise like a seagull is shouting. Right? It's called seagull tinnitus. So these are all the complications of cavity. Okay. How do you reduce the cavity problem?
Sir, cavity problems can be reduced by obliterating the cavity if possible during surgeries.
Okay, so one is obliterating the cavity. Second one is reconstruct the posterior canal wall. Third one is doing a canal wall up technique, avoid cavity. These are all the various ways of avoiding this thing. So how will you reduce the cavity size? What are the points you should keep in your mind?
So cavity size can be reduced by removing appropriate amount of normal tissue, sir.
Decrease, reduce?
Remove as
you
less
saturate the cavity very well so that all the soft tissue will get collapsed. If there's a cavity goes up to the tip, what do you do? It will form a sump. When the cavity comes up to the tip of the mastoid process will be lower than that of the floor of the external aortic canal. If that is the case, you got to amputate the tip, or you got to remove the outer wall of the mastoid tip so that make it wider so that your sternocleidomastoid mastoid muscle collapses inside and obliterate the cavity. Then you got to saturate the cavity very well so that surrounding soft tissue will go inside. If that is not sufficient, then you got to give you got to take the flaps. Okay, to reduce the cavity. So what are all the known flaps you know of?
Sir, anteriorly based Palva flap can be
Valvas
used.
flap, okay.
Then Guilford flap, sir, inferiorly
Okay.
based.
Inferiorly based flap, okay. Then
Norman flap, sir, also inferiorly based.
okay. You got to tell what flap it is.
Pedicled muscle flap.
Muscle flap, sternocleidomastoid muscle flap. Then
Temporalis muscle flaps.
temporalis muscle flap. Then
Then post-auricular muscles can be
auricular muscle. Like a periosteal flap. Periosteal flap, periosteal pericranial flaps. Then what is Rambo's flap? What is Rambo's flap?
Rambo's flap is temporalis facials.
Flap which contains both ends attached. So you bring it up and keep it inside the cavity. Then you can reduce the cavity size by filling up with the bone patty. When you operate, you take all the patties, keep it with you, and then you can use it to reduce the sumps. When one part is very deep, then you can fill it up. Or those parts can be filled up with your cartilages, particularly when you are doing a meatoconchoplasty, you remove a part of a cartilage. Cartilage can be used to reduce the cavity size. Okay. Then
Abdominal fat can
fat augmentation, right? Anything else outside material can be used? Artificial material?
sir, materials like porous ceramic materials or Teflon.
Hydroxyapatite. So various materials used to reconstruct the posterior canal wall or completely obliterate the cavity. Okay, so this will reduce the cavity problem. Okay, what are the canal wall up surgeries?
So canal wall up, simple mastectomy,
Okay,
cortical mastectomy.
that is simple mastectomy.
Simple mastectomy is just draining the mastoid abscess.
Okay.
So then cortical mastectomy, combined approach tympanoplasty.
Simple mastectomy, cortical mastectomy, Schwartz surgery, everything are all the various, the same surgery only. Okay. So complete mastectomy is the one where you remove the all the air cells, open up the four surgery, see the short process of incus. Okay. Then
Combined approach tympanoplasties.
okay, what are the what is combined approach tympanoplasty?
Sir, it is a canal wall up procedure in which cortical mastectomy is done, sir.
Cortical mastectomy is done. Then
Posterior tympanotomy is done.
okay.
Then transcanal tympanoplasty is done.
What? Transcanal tympanotomy.
Tympanotomy.
Tympanotomy. Okay. What is the intact bridge mastectomy? What is intact bridge mastectomy?
Sir, so only the mastoid air cells are removed with widening of the antrum, sir, but the bridge is not removed.
Intact bridge mastectomy is partly you do a canal wall down and partly you do canal wall up. So main purpose of this is to maintain the bridge so that the reconstruction to maintain the middle ear is easier. Okay, so you do an episiotomy, you do a mastectomy, you take a umbilical tape, put it between the undersurface of hiatus and clean the hiatus with the cholesteatoma. Then reconstruct middle ear and reconstruct the posterior canal wall. That's called intact bridge mastectomy. Okay. Okay, fine. So we have talked about What is retrograde mastectomy?
Sir, in retrograde mastectomy, transcanal approach, sir, in which first atticotomy is done and it is extended posteriorly into the antrum. Depending upon the extent of the disease, mastoid air cells are also removed, sir.
Retrograde mastectomy is otherwise called the inside-out technique, where you start the disease from the starting point, that's the posterior superior area, or it starts from the attic, then goes to additus, antrum, and stop as soon as the disease stops. So the idea is you make a small cavity. Small cavity is easier for you to manage when you do a modified canal wall down or canal wall up. When you go from the attic to the antrum, it's called retrograde mastectomy. Okay. What was the use of endoscope in mastectomy?
So use. Sir,
what was the use of endoscope in cholesteatoma surgery?
Sir, endoscopes can be used to inspect the attic.
Okay.
And sinus tympani.
Okay.
Sir, any disease in the anterior epitympanum, sir.
Sarah, you are talking from Madras Medical College. So the endoscope can be used to do the inspection, or you can do a complete cholesteatoma surgery with a endoscope, right? So usually they say you don't take up the cases when the cholesteatoma goes lateral to the lateral semicircular canal. Okay, but in our college we do it for almost any extent of cholesteatoma. You can do it with an endoscope. Okay, so you keep removing the outer attic wall, inspect the cholesteatoma and follow the cholesteatoma. The advantages of endoscopes are it's easier to look into the crevices like sinus tympani, facial features, hypotympanum, any anterior epidermis without removing much of the bone. When you remove the small amount of the bone, reconstruction of the posterior canal wall is much easier. When you remove a large amount of bone, the posterior canal wall reconstruction is very less. Okay. What are the complications of cholesteatoma surgery?
So complications include injury to various structures like ossicles, facial nerve, chorda tympani, sinus plate, dural.
Chorda tympani. What will you do to chorda tympani in a modified radical mastectomy?
Sir, when the bridge is being reduced, there are chances of injury.
You preserve chorda tympani?
No, sir.
Have you seen chorda tympani in MRL?
No.
You can't preserve, no. When you do a good modified radical mastectomy, the chorda tympani is bound to get cut. Okay. If that, most of the time you don't even see chorda tympani. So when you stretch the chorda tympani or cut the chorda tympani, what happens?
Stretching can produce abnormal metallic taste sensation for the patient. Cutting
you cut the chorda tympani, patient will lose the taste, right? Have you ever seen a modified radical mastectomy patient complains of taste? Loss of taste? Why?
No. Because opposite side is
when you do a staphylectomy, you don't overtake, is it?
The patient is not.
Surgery, same thing is true also, no?
So because of the opposite side, patient is not able to appreciate the deficits.
Sarah, for the staphylectomy also the same thing is true, isn't it?
Yes, sir.
Then why this patient complains of problem? Other patient doesn't complain of problem. See, when the disease happens around the attic. Attic is the place the cauda tympani goes. So cauda tympani from the beginning slowly going in for infection. Okay, because of that, cauda tympani function slowly comes down. Because it's a slow growing process, then alternate pathway takes away already. Already patient taste will be managed by the alternate pathway. So even when you do a good modified radical mastectomy, stitch or cut the cauda tympani, nothing happens. But when you do it in the staphylectomy, it's a virgin field. So you have a problem. You understand? Yes. So that is why modified radical mastectomy will not have injury of the cauda tympani. Okay? Right. How the sensitive hearing loss comes in modified radical mastectomy?
Sir, it could be because of drilling around, because of the heat of the
drill injury can produce high frequency sensitive hearing loss. Then,
sir, excessive ossicular manipulation can go.
You are insulting the surgeon. Okay. Then,
sir, any injury to the lateral semicircular canal or vestibular.
Then. The infective material can go through the oval window or round window, can produce sensory hearing loss. Okay, then injury to the oval window or round window can cause sensory hearing loss. So all these conditions produces sensory hearing loss. Okay?
Yes, sir.
Okay, so somebody has asked, please repeat cauda tympani. Okay, in a case of a cholesteatoma, cauda tympani gets affected early. So there's a slow growing process. So there are two alternate pathways for the taste is already started getting working. So when you do the surgery at that time, already there is an alternate pathway. So the MRM will not produce taste disturbance. While when you do a staphylectomy, it's a virgin field. Nothing has happened. So because of that, when you stretch it, it produces problem. Okay, right. Then sensory hearing loss. Okay, so what are the other complications? Facial nerve injury. Where do you injure the facial nerve?
Sir,
just now we were talking about you asking about facial nerve, and exactly I told and you are asking. Great. Facial nerve. Everybody is expecting facial nerve from you.
Okay. Tell me, where do you injure facial nerve?
So most commonly injured at the second genu, sir.
Second genu, yes. Then anywhere else?
Vertical part of facial nerve can be injured.
Vertical part of facial nerve. First genu you can injure. Okay, geniculate ganglion you can injure. Particularly whenever there is a cholesteatoma over the footplate of stapes, you can injure the facial nerve. Okay, dehiscent facial nerve can be injured. What do you do when the patient has got a cholesteatoma with facial palsy?
Sir, we explore we see the attachment of if there is any erosion of the facial canal, sir, or there is anatomical dehiscence of the facial canal.
Okay. What do you do?
Sir,
suture?
It is shaved off from the facial nerve, sir, cholesteatoma.
Okay. Then why there is a facial palsy usually?
So usually because of the inflammation in the granulation tissue.
Granulation tissue causes edema of the nerve. The nerve is inside the canal. So once the nerve is inside the canal, there is a occlusion of the nerve because it can't expand outside. It expands inside, causes axoplasmic flow to block. This axoplasmic flow block produces the injury to the nerve. Okay, this causes degeneration up to the level of the previous ganglia. Okay, so what you should do?
Sir, any granulation tissue can be removed, sir, and facial nerve decompression can be done.
Facial nerve got to be decompressed. Once you decompress the facial nerve, you see the nerve sheath. The sheath is stretching too much. You got to make an incision of the sheath. Okay, when you do a extensive cholesteatoma surgery, how do you identify facial nerve? What are the landmarks for identification of the facial
processus
nerve?
cochleariformis.
Process cochleariformis, most persistent
Processus cochleariformis is a landmark, sir.
landmark. Any other landmark? What is cog? See, the head of the malleus is got attached to the roughened area. Head of the malleus has got a superior malleolar ligament. It gets attached to a roughened area and the tegment. Okay, from that area to the at the level of the process cochleariformis, there is a transverse crest or vertical crest. Okay, that vertical crest is called the cog. It is not present normally. You can see that only when you remove the ossicles. When you do a modified radical mastectomy, only you can see it. Otherwise, when you see, you can't see that. So that's the most consistent landmark, which is not getting affected by the cholesteatoma. Okay. So what is the landmark for the second genome?
So second genome is posterior superior to the oval window, sir.
It is between the lateral semicircular canal and the oval window. Okay, the angle of a lateral semicircular canal and oval window, in between it takes the bend. Okay, what is the landmark for the upper part of the facial nerve? Vertical part of the facial nerve. One structure getting attached to the facial canal on its upper part. What is that?
Pyramid.
Pyramid. Okay, lower part?
Sir, pyramidal process can be.
That is the upper part. Then
Lower part by digastric ridge, sir.
facial nerve is always medial to the digastric ridge. Okay, then any other suture?
Sir, no. Tympanomastoid.
Always
Suture.
medial to the tympanomastoid suture line. Okay, so these are all the landmarks. For lowest landmark is stylomastoid foramen, digastric ridge, tympanomastoid suture line, pyramid, in between the lateral semicircular canal and the footplate of stapes, and then it goes to the first genu, process cochleariformis, and then the cog. These are all the landmarks of the facial nerve. Okay, then how do you reduce the facial ridge?
Sir,
What burr you use?
Diamond burr, sir.
Diamond burr. Will the diamond burr cause injury? Which burr will produce more injury?
Sir, heat production is more with
diamond
burrs.
Diamond burr. So when you are doing with the diamond burr, you will not destroy the nerve, but you will injure the nerve by producing more heat. You want to be very careful. You want to irrigate with the copious amount of water. Okay. So when you decompress the facial nerve, how far you will decompress? You see a Dyson,
sir,
right?
it should be
where the nerve is bulging, and you see there's a perimatric inflammation, and there's a small granulation tissue. You have removed all the granulation tissues. Now you see the nerve is bulging. How far you will decompress it?
Sir, 1 centimeter proximal and 1 centimeter distal to the bulge. It has to be.
Very good. Very good. You decompress till 1 centimeter. It is bulging. Then what do you do?
Sir, it can be extended further.
Then what's the point of 1 centimeter? Usually it doesn't go beyond 1 centimeter. Okay, so you got to to decompress 1 centimeter anteriorly and 1 centimeter superiorly and 1 centimeter inferiorly till you see the normal nerve. The bulging nerve should become normal inside the sheath. So then you got to incise the sheath. How do you incise the sheath? What instrument you use?
A sharp instrument has to be used and put a linear incision has to be made on the epineurium, sir.
There is a knife called tenotomy knife. Tenotomy knife used in the eye. That's an ideal instrument. Or you can use a sharp 11 blade. Okay, to make an incision on the epineurium. Or you can use a sickle knife. Okay.
Yes.
So this is about the decompression of the facial nerve. We have talked about the facial nerve. Okay, you have a lateral semicircular, you have a sinus, lateral sinus thrombosis. What do they do? You open up, you see a white structure, cord-like structure.
Lateral sinus thrombosis.
What?
Yes, sir. Sir, first the sinus plate has to be thinned out, and then needle can be inserted, sir. And if there is a free flow of blood, then it means that the sinus is patent, sir. If there is no free flow, then there is sinus is pale.
Then your diagnosis is wrong. What is the pathogenesis of the lateral sinus thrombosis?
Sir, initially there will be perisinus inflammation and followed by thrombus formation, sir.
Perisinus abscess. Perisinus abscess will cause the tunica adventitia inflammation, which will go on to the tunica media and tunica intima. Once the tunica intima is inflamed, the smoothness, that endothelium is velvet-like smooth. That's why it don't aggregate platelets. So it will become roughened. The roughened part will produce platelet aggression. So this is the infected thrombus. So it will slowly obstruct the whole of the thrombus, the whole of the lumen. Then it propagates. It can propagate down and up. It can go superiorly, or it can. What is lateral sinus?
Sir, sigmoid sinus and transverse sinus together known as lateral sinus.
Sigmoid sinus and transverse sinus together is known as lateral sinus. That is, you have a vertical sinus, you have a superior sagittal sinus. It divides, it turns one side and one on the opposite side from the inferior sagittal sinus. So that from there, the confluence of sinuses, from there the transverse sinus and the sigmoid sinus put together is called the lateral sinus. So there will be an axis. The whole sinus can be obliterated. There may not be any lumen at all. Inside also there may be abscess. So first you decompress the bone, remove all the pus, remove all the infected material, incise the sinus. Okay, once you incise the sinus, the old teaching is they used to tell that remove the thrombus till you get the fresh bleeding. But nowadays we don't do it. We can ligate, or you can we can close the sinuses with the gel foam. You plug in the sinus between the sinus wall and the bone, so that you obliterate the sinuses. That will close easily. Will you do a metaplasty then?
No, sir, meatoplasty cannot be done. If sinus is exposed.
Sinus exposed, you still do a metaplasty, because that will get obliterated by itself. Okay, if you don't do any complication, it's always safer to do a modified radical mastectomy. Okay, right. Why you want to check the other side?
Sir?
Why you want to check the sinus patency on the opposite side?
Sir, because the collateral flow has to be established, sir. If it is not patent, patient will develop hydrocephalus, sir.
Patient will not develop hydrocephalus. Patient will develop brain edema. If you ligate one interjugular vein, there will be two-fold rights in the intracranial tension. Okay, if you ligate on both sides, or if the opposite side is already a very small sinus, you ligate on this side also, there will be a five-fold increase intracranial tension. So that will produce brain edema, facial edema, brain edema, everything. So that's why you got to check, always check on the opposite side. I took the clue from Janakram, who's giving the answers.
I'm trying to answer your questions, boss. I'm trying to pass the exam.
For your information, myself and Janakram are classmates from MBBS, DLO, MS. And we used to fight like mad for the subject.
And Anthony always used to win. Because he's
Not that I used to win. And then most of the time we never talk anything else. We never used to talk about girls. We never used to talk about cricket. We never used to talk about sports. We never used to talk about, if at all we talk something, we talk about music or only subject. For 11 years we have been talking only subject, which is sickening. Okay, so right, fine. Then I think we are coming to the conclusion, right? So what is malice, mastoid, misery? What is malice, mastoid, misery? See, when you see a patient who has got a cholesteatoma, patient has got certain problems. Okay, certain problems like patient got a ear discharge, patient got pain, patient got wax accumulation, patient gets tinnitus, and patient gets doctor dependency. Okay, so these 5 things are there when the patient has got a cholesteatoma, and then you got to score that 1, 2, 3 for mild, moderate, severe. Then after surgery, you got to score it again. When you see a score of the pre-operative period is more than that of the score of the post-operative, that's fine. If the post-operative score is more, then that is called malice, mastoid, misery. Called mastoid misery. So it's a you got a poor cavity and got poor patient is having the persistent problem in spite of doing surgery. Okay. Right?
Yes, sir.
What mastoid misery?
Malice, M-A-L-E, malice, mastoid misery. There is there in the 6th edition Scott 1 pediatric volume.
Malice. நம்ம ஒரு மாலி ஞாபகம் வச்சுக்கோங்க.
Okay, so the ideal cholestoma management is you give a ear, safe ear, dry ear, functioning ear, then anatomically near normal ear. If you can compromise on one, that is anatomical near normal ear, then you can give a canal wall down surgeries. So canal wall down surgery is known to produce cavities. Cavities are known to create problems. Sometimes the problem will be more compared with that of the surgery itself. But we are not operating for the problems. We are going to convert an unsafe ear into a safe ear. If you achieve that, that's fine in spite of being malice, mastoid, misery. Okay. So can you conclude?
Yes, sir.
Janakram? So any questions?
Have we talked about obliteration? I think you have done it. Okay.
Yes, we have talked about it.
Okay. Now, I think, have you completed the presentation? All the questions are over? Professor
I think so.
Okay. So, if you have completed, then I think I should really congratulate Dr. Sara. Wonderful presentation, Professor Dr. Sara. You're really fantastic. And of course, trained by Professor Anthony will definitely give that qualification. So let me just tell the audience a few things. Number one is that we have finished the ear case and successfully, and I'm sure that you have got a lot of questions, and the genius himself, Dr. Professor Anthony, has actually interviewed Dr. Sara and given you a lot of insights. Number one. Number two is that we are going to have a nose case tomorrow. Can you tell about the nose case so that they will read and come, the postgraduates? What is the case you're going to keep?
I'm going to keep CA maxilla.
CA maxilla. Okay, CA maxilla. Fantastic. CA maxilla. One day you will finish it. No, tomorrow you will finish it.
Yeah. That's a short case only.
Okay, tomorrow we'll finish that, and so that will be for tomorrow. And then next Wednesday, Thursday, and Friday we'll have larynx and hypopharynx case, and that will be fantastic discussion by Professor Anthony. And dear postgraduates, now you can come on. You can show your faces and you can chat. We'll have a small discussion. What you actually want, in case you want anything else like recent advances, any topics, just come online. Now you can show your faces. We can talk. Can we have 5 minutes, Professor Anthony, with you?
I'm with you. It's the
Okay.
stage is
So,
yours.
my dear friends, you can just show your faces now if you want, and yeah, Harsha will try to unmute you. Come first, show your faces. All of you come. If you're there, come online. Okay. So now you can actually raise your hand if you have any thing we want to discuss, because Royal Pearl is dedicated to teaching, and you know that we do a lot of things for postgraduates all over India. You see, during the Corona period, all the postgraduates have suffered, not only in MMC, but throughout India and throughout the world also. So most of you might not have had rounds. So the problem is most of you might not have had rounds. That is why I thought, let me do a grand rounds, and also we'll cover a lot more topics like, what you want to tell me, we can do it. If you want some theory topics also, we can do that. We can call a lot of professors. Professor Anthony is there to help us. And if you want a specific college to be called also, we are ready. I can talk with the professors there and make it possible. We are planning to have many more till around, this is February, March 15th, we'll stop. Till March 15th, we'll be having some academic activity going on from 8 to 9. So 1 hour you can, I think it's your study holidays. So it'll be very useful for you to combine your this one practical along with your theory. There's no point going on reading. So like professors like Anthony, he can actually highlight on some topics. So you have any specific things you want to discuss, like for example, recent advances, or you want something like theory from the nose, cadaver dissection, or some surgery from the nose, then you tell me. I can arrange also larynx. I can arrange people. They're all willing to help us. Only thing is we have to ask. There's one person raising their hand. What is your name? What is her name? Unmute
Hi,
yourself.
sir. Good evening, sir. I am Anne. I'm
Anne.
from Cochin. Sir, I would like to hear a discussion about endoscopic anatomy of ear.
Endoscopic anatomy of ear. Okay, fine.
Yeah.
So what you will do, we'll write it down. I cannot ask Professor Anthony just like that. I have to ask him formally, and then we will plan it. So
Yeah,
that is
sure.
your request. We will do that. Okay.
Thank you,
Anybody
sir.
else? Any Dr. Aishwarya? Yeah, come out. What do you want? Actually, do you want
sir.
any? Yeah.
Good evening, sir. There was a wonderful class from Anthony, sir, and a good guidance from you also. So you want to click on imaging in rhinology, sir.
Okay, imaging in rhinology. Okay, fine. I think I can do that. I'll take imaging in rhinology for you. So
Okay.
I'll plan for one class for you. Imaging in rhinology, I will cover the whole thing. You want both MRI and CT scans. Maybe
Yes,
I can even arrange a super radiologist. Professor Savaram is there. We'll arrange for that. Okay, so we will take that for you.
Thank you, sir.
Okay. Any else? Anybody else? Somebody? Anamika, yes. Dr.
Yes, sir. Good evening, sir.
Yeah.
Sir, I would like to request you to have a session on imaging of temporal bone and temporal bone dissection, sir.
Temporal bone dissection and imaging, is it?
Imaging, sir.
Okay. Are you exam going PG?
Sir, I'm final year PG this year. I'll be appearing next year, sir.
Okay, see, I'll tell you one thing, doctor. This is primarily to take up the exams. Dissection and all we'll show definitely, but this is primarily for exam going PGs who are actually going to appear for the exam. So if you relate your topics to that, then we will cater it, because temporal bone
Okay, sir.
dissection and all, you know, it will not be directly useful for the exam going PGs. So
Okay,
primarily for the exam going PGs, I'm doing this. So yeah, Dr. Samina Ansar. Yeah.
Good evening, sir.
You're finding this program useful, Dr. Ansar?
Yes, sir. It was means I'm exam going in this May. My friend is also there. We are from AIMS Jodhpur, sir.
Where are you from?
Sir, AIMS Jodhpur.
AIMS Jodhpur. Okay, fine.
So we would like to have a class on instruments.
Instruments. Okay. You write it down. Yeah? Instruments in ENT. Okay, we'll do that. That is very important. I think, Professor Anthony, we have this one, is it? So in exam we have instruments in ENT. Okay.
Yes.
Okay.
Instruments
So
and the X-rays.
X-ray also, no? Instrument and
Yeah.
X-ray. Okay, we'll do that. Okay. Any of you guys want to present? Do you want to actually present like Dr. Sarah? You please tell me. Just give me a message. I'm of course not going to ask you now, but give me a message. We'll do it. Yeah. Anybody else has got any doubt? Anybody else? Okay, you can see my son is here, Dr. Satyanarayanan. He's also exam going now, and yeah. So, you have anything to ask, Dr. Satya? Nothing, huh? Okay.
They are over.
Okay. So, anybody else? I think we are done then. So tomorrow we'll have CA Maxilla. Please read up CA Maxilla. Who is going to present, Professor Anthony? Any candidate?
I'll check up tomorrow and tell you.
Okay. Right, Bhuneshwar is raising hand. Who is that Bhuneshwar? Yeah, come on live and ask. Bhuneshwar, where is he? Bhuneshwar, I don't know. Okay. Okay, fine. I am not able to see Bhuneshwari or Bhuneshwar, whoever it is. I'm not able to see them. So we'll say goodbye and thank you very much, Dr. Sarah, for wonderful presentation and taking your time out. God bless you. And of course, Professor Anthony, thanks a lot. And we want many more sessions from you. And we will try to steal your time. I'll come back to you after the talk and request. Yeah. Thank you very much, all of you. Have a good night. Thank you.
Thank you, sir.